صباح الخير. The topic of my presentation today will be splints. Splint is an appliance which is used for immobilization of soft and hard tissues until healing occurs. That's to say, it is used in the treatment of fractures. What's fracture? A jaw fracture is a facial injury that results in the jawbone breaking or moving out of position. Therefore, we can classify splints as a type of stents. Which type? Therapeutic device stents. Why? Because it is used for doing a therapeutic purpose, which is the treatment of fractures. What are the types of fractures? We classify fractures into two main types: simple fracture and compound fracture. In simple fracture, the bone fracture is not associated with open wound and it does not require open reduction. What is the open reduction? Regarding fractures, the management of fracture is either done without the need for surgery, and we call it closed reduction, or with the need for surgery, and we call it open reduction. Therefore, simple fractures does not require open reduction. Simple fractures can be classified into three types: green stick fracture, which is the most common type in children. Second type is fracture with no displacement, or what we call it linear fracture. Third type is fracture with minimal displacement. What's green stick fracture? Green stick fracture is that the fracture segments are not separated from each other. They are still connected. عارفين زي ما كنا زمان بنكسر عود القصب، لما تيجي تكسره هتلاقيه اتكسر نصين ولسه القشرة ماسكة الجزئين اللي اتكسروا مع بعض. نفس الكلام بيحصل هنا، بيحصل في الأطفال لأن البون بتاعهم لسه سوفت، فبيحصل لهم what we call green stick fracture. في الادلتس بقى بيحصل fractures with separation of the fractured segments. That's to say, we have fracture with, and the two fractured segments are separated from each other. So we classify these types: either fracture with no displacement, that's to say, the fractured segments are not displaced from each other, they are still in the same position, or fracture with minimal displacement, that's to say, there is some displacement but the displacement is not severe. The other type of fracture is called compound fracture. In compound fracture, there is an open wound. It is severe with tooth-bearing area fractures, that's to say, fractures occur in the area of tooth-bearing. It's very, very severe. The compound fracture require open reduction. Sometimes, as you know, we may lose a tooth in the fracture line to correct the fracture. After fracture, I lose a tooth in the fracture line. In the compound fracture, we require open reduction. We need to go to the surgical theater and open a flap and return the fracture segments together and use a plate or screw for fixing these segments. What are the sites of fractures? بيحصل فين؟ There are 5 sites for fractures. Most common is the condyle fracture. Why? When anyone falls, the hit usually comes to the chin. The hit to the chin, the most weak point is the neck of the condyle. So, the condyle fracture can be considered the most common mandibular fracture. It occurs either unilateral or bilateral, that's to say, only in one condyle or in both condyles. Also, it occurs either intracapsular or extracapsular. That's to say, either the fracture is within the temporomandibular joint capsule or outside the temporomandibular joint capsule. The other side for fractures is we call it angle fracture or ramus fracture. That's to say the fracture occurs in the body of the mandible, either at the angle area or in the ramus area. Third type is the parasymphyseal fracture. Parasymphyseal fracture occurs in the area of the canine, in the area of canine region, and we call it parasymphyseal fracture. All fracture occurs in the middle line, exactly in the middle line, and we call it symphysis fracture. The most rare type is the cronoid fracture. That's to say, the condyle is intact and the cronoid process is fractured. Therefore, management of fracture is either carried out surgically using open reduction or prosthetically using closed reduction. The prosthetic management of the fractures, we use splints. A splint is an appliance used for immobilization of soft and hard tissues until healing occurs. Uses of splints. Main use is in the treatment of fractures. However, there is other uses. It can aid in plastic surgery of facial structures, for example, in treatment of prognathizm. That's to say, we can use a splint in case of orthognathic surgery, in which we are correcting the prognathizm in one or both arches. We will need a splint to fix the jaw after surgical correction. Also, it can be used in conjunction with bone or metal graft of jaw bones. Sometimes we need to graft part of the bone and we need a splint to hold the grafted part of the mandible until healing takes place. Also, in periodontal treatment, it can be used to support mobile teeth. If I have some periodontal affected teeth, I can use a splint to support these teeth until healing occurs. Requirements of a splint. There are many requirements for a good splint. First, enough rigidity and immobility. That's to say, allow good fixation of the fragments for a long period of time. Biologically compatible, comfortable and reliable for the patient. Do not harm the teeth and supporting structures. It should be very easy to construct, so speed and easy production is very important. Also, easy to handle and does not require any special instrumentation or laboratory procedure or extra session of anesthesia to place the stent. Adaptable into required shapes and available in different sizes. Stable and does not interfere with feeding, swallowing, as well as minimum disturbance to normal functions. Fixation should cause the least minimum possible interference to occlusion. Should cause the least minimum possible interference to occlusion. Also, early movement of the mandible can be attained to prevent trismus. Let's say I can remove the fixation of the splint with the other jaw to allow some movement of the mandible to prevent trismus. In addition, it should need little post-operative attention. In general, the methods of immobilization of the teeth in closed reduction situation are as follows. We classified into two types according to the type of the patient, for dentures patient and for edentulous patient. For immobilization of fractured segments in dentures patient, we use wire loops, arch bars, labiolingual splint, or what we call it stout acrylic splint, and metal cap splint, and this is somewhat an old modality, and the fifth type is a lingual splint. For edentulous patients, we have two types, the gunning splint, which is later modified to modified gunning splint, and the Kingsley splint, and this Kingsley splint is a very old model. It has to be noted that the maxilla is utilized as a stable base for immobilization of the fractured mandible. When I have a fractured mandible, I will use the maxilla as a stable base to hold the mandible until healing of the fracture occurs. For dentures patients, the first method is wire loops, or sometimes we call it IV loops, or direct wiring or eyelet wiring, in which you place a wire in the embrasure between posterior teeth on both sides, in the upper arch and in the lower arch, and then the loop made in this wire is attached in both arches using ligature wire. Therefore, we have to use IMF or intermaxillary fixation to fix the fractured mandible to the stable base, which is the maxilla. Therefore, I usually place wire loops in the upper arch and in the lower arch. Of course, we can, after some time, remove the IMF to allow early movement of the mandible to prevent trismus, which is limitation in the mouth opening, as we will discuss in the next lecture. Also, to fix these IV loops or eyelet wiring, I need sufficient number of teeth. So it is used in patients with complete or almost complete set of teeth with normal shape and size. Second type is Archward. Archbar are used when the patient has insufficient number of suitably shaped teeth to enable effective interdental eyelet wiring to be carried out. If I don't have sufficient number of teeth, or the teeth are not suitably shaped, that's to say conical in shape or somewhat, so therefore eyelet wiring will be lost easily, I will use the Archbar. Archbar comes in a ready-made form. It is a metal bar with hooks. We fix one in the upper arch and another one in the lower arch. In the upper arch, we make the hook facing upwards, and in the lower arch, we make the hook facing downwards. This arch bar is wired to the teeth from the second molar to the second molar, in the upper arch and the lower arch. Then we use IMF or intermaxillary fixation, fixing both arches together. And this type is used when I have, as I said, insufficient number of suitably shaped teeth to enable effective interdental eyelet wiring to be carried out. Third type, which is commonly used in children, is called labialingual splint or stout sectional splint or split acrylic splint. Why we call it like this? Because it is separated from the labial side in order to allow easy placement in the patient mouth, and then these parts are connected together. Why we call it stout? Stout means a small, narrow and rigid part shaped like mushroom. That's to say, it has a constriction in the neck and a wider area outside. This bottom or stout is made in the middle line from the labial side, and after construction it is separated into two parts. And after placement in the patient mouth, we can wire the two parts of the bottom together. Therefore, we call it also a split acrylic splint because the labial part is separated into two parts. Therefore, labialingual splint is an acrylic splint covering the buccal, labial as well as lingual surfaces of the teeth, and leaving the occlusal surface uncovered, and I will have stainless steel wires connecting the two acrylic portions posteriorly around the last remaining tooth. Therefore, a wire will connect the lingual part of the splint with the labial and buccal part, and this wire will pass around the last molar tooth. Used in dentures or partial dentures patients without or with minimal displacement of the fractured segments and commonly it is the one most commonly used in children. It is the most common type to be used in children. Construction. First, accurate alginate impression is needed of the lower arch. Should record the vestibule and all the teeth and soft tissue undercuts. Then the splint is waxed up. The occlusal surface must be left free. A sheet of wax is adapted starting from the height of contour of the tooth to the depth of the vestibule. We start the waxing up from the height of contour of the tooth to the depth of the vestibule. Then stainless steel wires of 9 gauge, 15 cm, half round cross section is bent and placed distal to the last molar and embedded in the wax so that the buccal part of the wax is attached to the lingual one through this wire. We can make some contra angle or bending at the end of the wire for mechanical retention inside the wax and later on inside the stent. After waxing up of the stent, we will make a button like in wax or a mushroom shaped part in the middle line in the labial side, placed in the front region of the splint. Before processing, the part of the teeth above the survey line is usually sewed. That's to say, we remove it completely from the cast to facilitate removal of the splint from the cast after processing. The splint is flattened and processed into clear acrylic resin. After polishing, holes are drilled at the interproximal areas so that I can wire the splint to the molar teeth to ensure its fixation around the mandible until healing takes place. So holes are drilled at the interproximal area posteriorly to allow wiring of the splint over the contact areas. Then the splint is sectioned at the middle line of the button vertically by separating disc so that the splint can be easily inserted in the patient mouth by the help of the flexibility of the wire placed behind the last molar tooth. The fracture is then reduced under local anesthesia. That's to say, we give anesthesia to the patient and we try to reduce the fracture to the normal relation guided by the occlusion of the maxilla. Then the splint is fitted in place using ligature wire around the button. Therefore, it's very easy to be placed. And then I use the ligature wire to hold each half of the button together. It has to be noted that the splint may be lined by soft liner before fixation. هحكي لكم حكاية. كان جالي ولد صغير 4 سنين عنده فراكشر مانديبل فين؟ في الباراسمفيزيال ريجن. فحبيت اسأل جاله ازاي. طلع الولد هم عندهم مزرعة، اتسحب كده ودخل في الحتة اللي فيها الحصانة وراح على الحصان وابتدى زغزغه في رجله اللي ورا. اول ما عمل كده اداله 1 هيت على طول عملت له باراسمفيزيال فراكشر. ففي الاطفال ميزة السبلنت ان هو سهل انك تعمله. هتاخد له امبريشن. لو مفيش ديسبليسمنت خير وبركة. لو في ديسبليسمنت ممكن تاخد upper impression وتبتدي تعمل سوم للكاست وترجع ريليشن للنورمال guided by the opposing occlusion وتعمل بيز للكاست وبعد كده تبتدي تكونستراكت السبلنت على النورمال ريليشن. وبالتالي اما انا احطه هعمل ريدكشن قبل ما احطه، ادي انستيزيا واعمل ريدكشن، ارجع الفراكشر سيجمنتس مظبوط في مكانها وبعدين احط الايه ليبيولينجوال سبلنت. Advantages: ease of fabrication, not interfering with the function or occlusion, made of acrylic resin so X-ray is possible to ensure the healing of the fracture, could be removed every few days to avoid trismus. The other type is called metal cast splint or silver copper alloy cap splint. It's called cap splint because at first they constructed covering the occlusal surface. Later on they modified this splint and they call it metal cast splint and removed the term cap because they construct the splint without covering the occlusal surface in order to avoid interference with occlusion, and in this situation we call it metal cast splint. But before we call this splint as cast cap splint because it covers the occlusal surface. It is a metal splint covering the buccal, lingual and occlusal aspects of the teeth on either sides of the fracture. It does not cover the proximal surfaces. Therefore, it's only from the buccal and lingual side. It can be in the form of either one piece or two pieces. One piece cap splint or simple cap splint used only when there is no displacement or little displacement of the fractured segments. The fragments can be easily positioned by the occlusion with the opposing teeth. بمعنى ان انا قبل ما اعمله لازم ارجع الريليشن للنورم. مفيش ديسبليسمنت، خلاص لو في ديسبليسمنت هعتمد على الاوبوزنج اوكلوجن ان انا هعمل سوينج للكاست عند الاريا اوف ديسبليسمنت وبعدين ارجعه تاني guided by the opposing occlusion in the proper occlusion, fix it with the sticky wax and do a base for the cast. Therefore the cast is constructed to be in the normal relation with no displacement. At the time of placement I can give anesthesia and do closed reduction of the fracture segments to the proper relation and place the splint. The two-piece metal cap splint, or as I said, you can say metal cast splint if it is not covering the occlusal surface. It is a cap splint with screw connecting bars. We can call it sectional cap splint with localizing plate. It is used when there is displacement between the fractured segment. It provides more rigid fixation to hold the fractured segments after correcting the displacement. The two parts of the splints is connected by a bar and screws. Although it provides rigid and efficient form of reduction and immobilization, but it is considered as one of the old modalities and is not used nowadays because first it may interfere with occlusion. However, I can overcome this by constructing a metal cast splint without covering the occlusal surface. Second, the black copper cement used for cementation of this stent is very strong, which may lead to jaw fracture during splint removal. It's very strong after cementation and its removal is very difficult. What is the idea of the bar and the screws? The bar and screws will help the reassembling of the two parts when I have severe displacement. That's to say, I construct, if I have a fracture and the fractured segments are displaced, I will construct one piece of this metal splint on each part. Then I will fix a plate in which I can fix a screw in one part and another plate in which we can fix a screw on the other parts. Then I have a bar with two holes. Therefore, I can give anesthesia and then approximate the two parts together after cementation of each part of the splint. So I cement each part to each fractured segment without connecting the bar. Then I give anesthesia, I make a reduction, I return the fractured segments in the proper position guided by the opposite occlusion. Then I will use the bar and screw this bar to both segments, therefore it is now fixed in position. That's why we use it in case of severe displacement. If I have minimal displacement, I can use the one-piece metal splint. Another type of splint which is very common is called lingual splint. Lingual splint is an acrylic part with wires connected to it to be wired around the teeth. The acrylic part is only from the lingual side, so it is used only when I have minimal displacement. I can use it in case of severe displacement. It is a splint conforming to the inner aspect of the dental arch. It is the most common splint to be used nowadays because it's very easy and very simple and not annoying for the patient. Used mainly in parasymphyseal fracture of the mandible. Why parasymphyseal fracture? Because it's very easy to return it back into the proper position. However, for symphyseal fracture, the symphysis region is more difficult to construct than the mandibular body due to the abrupt curvature of the bone in this area. That's why the abrupt curvature, I can have some displacement in the segments, slightly anterior or slightly posterior, and therefore we use it only in parasymphyseal fracture cases. Then we come for edentulous patients. For edentulous patients, as I said, we have the gunning splint and the Kingsley splint. As I said before, the maxilla is utilized as a stable base for immobilization of the fractured segments of the mandible until healing. Gunning splint. Gunning splint is constructed for both arches as one piece. So its disadvantage is that it is overworked, difficult to manipulate, it cannot be wired to the jaw bones. تخيل كده لو السبلنت بالحجم ده وانت محتاج تحطه as one piece in the patient mouth، والعين ده طبعا عنده fracture وعنده pain. الحاجة التانية لما تحطه كده هتعمل وايرنج ازاي؟ هتثبته ازاي في الجوز؟ الابر اوكي ممكن تثبته circumferential وايرنج، لكن اللور مش هتقدر تعمل circumferential وايرنج مثبت الستنت ده حوالين الماندبل لغاية ما يحصل هيل، وبالتالي it's not very effective. That's why we shifted to the modified gunning splint, or what we call it two-piece gunning splint. The two-piece gunning splint consists of two separate splints, one for the upper and one for the lower. Also, we place V-shaped grooves on the occlusal surface, similar to that made during generation registration. I place it on the occlusal surface of one arch, and I will have a projection in the opposing arch. Whether in the upper or in the lower, it doesn't differ. These projections will fit into the grooves of the opposite arch to maintain the relation between the two parts. Steps of construction is very easy. Upper and lower impressions are made. Cast preparation is carried out. 2 layers of modeling wax are adapted on the cast, 2 mm shorter than the anatomical outline. Why? First, why 2 layers and why shorter than the anatomical outline? 2 layers because I will reline this stent later using tissue conditioning material. So I will remove the inner layer and take the outer layer for flasking. Why shorter than the anatomical outline? To ensure that the tissue conditioning material is covering all the borders and it will be gentle for the patient during the period of fixation, which is about 45 days until healing takes place. We construct occlusal bite rims constructed for each arch with a space in the anterior teeth to facilitate the function of breathing, feeding and possible vomiting. بمعنى أنا هعمله كله من الواكس شبه الريكورد بيس، ولكن الانتيريور بارت is removed، يعني posterior يمين وشمال في الابر واللور، ومن قدام مفيش واكس. بعد كده هنحوله كله into acrylic resin. Vertical and syncopation are recorded from the patient and the models are mounted on an articulator in the preparation. If the vertical dimension or syncopation cannot be obtained, so roughly I adjust to be equal to 5 mm for the upper and lower wax rim. That's to say, if I cannot record the jaw relation properly because of the pain due to the fracture, I will construct the upper wax rim in the posterior part to be 5 mm in height and the lower 5 mm in height. Then I have to make the male and female buttons 3 to 5 mm deep, a groove in one of them and a projection in the other one, so that the splints can be interlocked to maintain proper centrifugation in the patient mouth. Also, I have to place 2 or 4 stainless steel wire loops or hooks placed on the posterior side. I will place 2 on each side, that's to say 4 loops in the upper and 4 loops in the lower. These are placed in the area of the buccal flange in the waxed up bases. Why? To help the fixation of the splint. The upper one, as I said, it will be fixed to the maxilla through circumzygomatic wiring. The lower one I will use circumferential wiring. Then the intermaxillary fixation of these two parts is carried out by using ligature wire between the loops in the upper and the loops in the lower. Flasking and processing is made after removing the inner layer of the wax, as I said, to allow space for soft liner placement after processing, to be gentle for the tissues in order to allow the patient to withstand this stent in his mouth for 45 days. As I said before, the mandibular splint will fix it using circumferential wiring passing around the stent and around the mandible. The maxillary splint is suspended to the zygomatic arch, and we call this procedure circumzygomatic wire. Then the two splints are attached to each other in the patient mouth by filling the V-shaped channel with either black gataperca or self-cured resin. Therefore, the two parts are fixed together properly. In addition, the two splints are wired together using intermaxillary fixation. So, after using the black gataperca or a self-curing resin to fix the two parts in the proper relation, I have to fix it properly using intermaxillary fixation by ligature wire, connecting the loops in the upper one with the loops in the lower one. The two splints are wired together. After healing, the wires can be removed for a period of time to allow easy mobility of the mandible. That's to say, before removal of the splint completely, I will remove only the intermaxillary fixation and leave the upper splint connected to the upper arch and the lower splint connected to the lower arch. Therefore, the patient can move the mandible as early as possible to avoid the formation of treatments. طيب، لو العيان عنده طقم ينفع استخدمه ولا لا؟ عيان اوريدي جاي لي هو دنشر زي ما قلت لكم وعامل طقم. If the patient has an old denture, we can use it as follows. Cuts are poured and then mounted with no need for impression after blocking the undercuts. بمعنى هاخد الطقم بتاعه، هقفل الاندركاتس ببلاستيسين واصب كاست، بعدين اشيل الدنشر تاني عين، هاخد الكاست دول اعمل عليهم ايه؟ الكونستراكشن بتاع الستين بنفس الخطوات بالظبط. That's to say, dentures are removed and the splint is waxed on the model. طيب، هل ممكن استخدم نفس الطقم؟ ممكن. في الحالة دي the denture itself can be used as a splint with extra oral bandage. يعني انا هحط له الطقم واعمل له extra oral bandage around the head to limit the movement of the mandible. during the healing period. ولكن طبعا زي ما قلت لكم ان انا استخدم الجانينج سبلنت هيبقى اسهل واكيوريت واضمن ان انا اضمن ال immobilization of the fracture segments until healing takes place. Steps of construction is very easy. Upper and lower impressions are made. Cast preparation is carried out. 2 layers of modeling wax are adapted on the cast 2 mm shorter than the anatomical outline. Why? First, why 2 layers and why shorter than the anatomical outline? 2 layers because I will reline this stent later using tissue conditioning material. So I will remove the inner layer and take the outer layer for flasking. Why shorter than the anatomical outline? To ensure that the tissue conditioning material is covering all the borders and it will be gentle for the patient during the period of fixation, which is about 45 days until healing takes place. مكون consists of an intraoral portion embracing the edentulous alveolar process to which stout wire arms are attached. بمعنى هيتعمل ازاي؟ هناخد impressions، بعدين هنعمل الكاست. قبل ما اعمل الكاست هعمل metal dart. Therefore the surface of the cast will be metal. Then I break sheet of wedged tin and I adapt this wedged tin to the cast and I cut the excess. Similar to what we call wedged tin base. As you studied in complete denture construction, one of the types of the record bases is the wedged tin. It's also historic. Then after adaptation I cut the excess, I smoothen the border, and then I have to connect to this stent an extra oral portion projecting between the lips and carried around the sides of the face to provide attachment for the bandage, passing either under the chin for the fracture mandible or over the head for the maxilla. So 2 round wires are soldered on the outer side of the wedged tin base, and these wires will extend outside the patient mouth, and I will use a bandage to fix the lower stent around the chin and the upper stent around the maxilla. So the Kingsley splint is fixed to the maxilla and the mandible, and I can use some form of fortil bandage to limit the movement of the mandible. Thank you so much.